Good afternoon. So going back, 1985 was when we first started using antibody 3F8. And you're going to throw tomatoes at me because I started this treatment, which is so painful for children. And I couldn't bear it, actually, when we started using it. And we had to stop that treatment for a whole year, trying to go back and kind of figure out what happened. Why is it there's a drug that we purified and it's still causing pain? But we charge on, and 30 years later, this is where we are. So if you look back at why we chose immunotherapy, and this is sort of a consensus, not in pediatrics, but in general in the cancer field, that there's an impression at least that while chemotherapy can shrink tumor, the tumors most of the time will come back. And even with small molecules, even though you get a response, they almost always become resistant. And you have to deal with it by either using a second generation, third generation agents. The thing about immunotherapy, and as we're looking at the PD-1, PD-L1 explosion, we realize that immunotherapy does have a chance of a cure. And when I said cure, I mean a curve that is flat, a survival curve that remains flat. And that is really important. And from the 1980s, late 80s, we're already looking at that and asked that question. This is our goal. This is what we want to do. We want to develop something that will give us a plateau in the survival curve, not just a pushing out the survival curve, but plateau in survival curve. And this is a cartoon that Dr. Modi alluded to. When we look at these antibodies, especially 3F8 or chimeric 1418, we kind of know pretty much what they can do and cannot do. What they can do is ADCC, antibody-dependent cell-mediated cytotoxicity, where a cell with an Fc receptor will grab the antibody, which is attached to the tumor, and basically kill the tumor for you. Now, the neutrophils can do it, the macrophage can do it, and NK cells can do it. And now we know a lot about how these effector cells can use the IgG to kill tumor. But there's one thing which is very obvious to all of us, that we haven't been able to use T cells over these decades to fight a tumor like neuroblastoma. And in fact, this is really something that, not that we don't want to do it, but there's some inherent issues why classic T cells would not work in neuroblastoma. One of the reasons being is that there's very little HLA molecules on the cell surface, and you need those molecules for the T cells to kill. And neuroblastoma don't have those molecules or have very little of those molecules. So that was one of the reasons. So in order to bypass that, we have to design something where we don't need the HLA. And this is something I'm going to talk about later on today. Of course, there are CAR T cells, and you heard Dr. Anderson talking about CAR T cells, which is another way to drive T cells to the tumor using an artificial receptor, a receptor that do not require HLA. But by the same token, we can build bispecific antibodies, which will do almost identical work. So back 30 years ago, when we started looking at antibody 3F8, the first thing we did was looking at biodistribution. Does it really go to the tumor that we want it to go? And it was quite obvious that when we look at a child with a neuroblastoma injected with a iodine-labeled antibody, you can see the antibody tracking to the tumor sites, the ribs, the skull, the pelvis, and not much anything else in a sense. Much of that is blood pooling, which is a reassurance that this antibody is not going to the brain, and there's the downside to it, and it's not going to some of the other places that we don't want. And because of that, we actually move ahead, and this is sort of summarized in this slide in the last essentially 30 years. So we started out looking at patients who are primary refractory, and these are patients with marrow disease or MIBG positivity at the end of induction. So they have not relapsed yet, but they have persistent disease at the end of induction. And we'll give them 3F8 plus GM-CSF. And this is a 15-year follow-up, and we can see that there's a curve which is reasonable, but not ideal, meaning that there are long-term survivors and look like some of these children may be cured. So despite the fact that they're primary refractory disease, you could use a single antibody, a single target, and nothing else, and you could potentially cure a child. And this is very important, and I want to come back to that later on. A single antibody and a single target, which is not something that you expect because of heterogeneity in tumors. There are only a few examples in cancer field. I think CD20 is one of them for lymphoma, and HER2 for breast cancer. These are the only other few examples where a single antibody can make a big difference in the outcome of the patient. So based on the primary refractory study, which is about 79 patients using 3F8 plus GM-CSF, we do not use IL-2 because of the toxicity from the IL-2. And we don't think that actually adds that much to the GM-CSF. We actually continue on a second remission protocol. These are patients who have relapsed, got back into remission, and treated with the antibody. Now, some of these patients have up to 6 relapses and got back into remission, and we treat them with the antibody. And the outcome for that is, again, past 10 years from the time of relapse or the antibody treatment, again, we see a plateau in the curve suggesting that a good percent of these children, I think, are cured. Now, it's hard to measure a cure. When our patients come back, having a family, having a child, a baby, that's what I mean. For me, it's cure because life passes on. I can't live until they're 80 years old to know that they're cured. But this is something that we're going to hope for, that this will continue for good. And then we went to the first remission group, and these are patients who have induction therapy, and they go on to 3F8 plus GM-CSF, and our overall outcome is reasonable. I don't think it's something to be so excited about, but it's still a lot better than when I started out 30 years ago when there were no survivors. I was extremely disappointed with myself and aggravated by the whole thing that none of my patients diagnosed at that time, more than 18 months of age, ever survived. Compared to now, this is a very big change in the natural history of disease. We also looked at MRD. Now, this is one thing that we've been focusing on a lot because we are beginning to use these agents or therapeutic methods in patients who have very low volume of tumor. Such a low volume that you could not detect it by CT scan or MIBG scan. The only way you can find them is using very sensitive methods like PCR. And this is what we've been doing, looking at PCR of the bone marrow. Now, obviously, we're doing now with blood. I think blood cell-free DNA, which is a challenge, is probably the next generation of markers. But using bone marrow, we were able to show that using a four-marker panel was highly predictive. Once we got the immunotherapy, 2 cycles, we repeat the bone marrow, and you do the test. Those patients who are MRD positive uniformly relapse, and those who are MRD negative have a much better chance of overall survival. And this is a test we think is going to be really able to guide us from here on, looking at patients in remission or any therapy that's given as an adjuvant. So here's the part that I mentioned. The fact that it doesn't get to the brain has a downside. Antibodies cannot travel to the brain, and therefore it doesn't cause toxicity. But by the same token, we start seeing patients coming back to us about 15 years ago with brain metastases. These are isolated brain metastases, which is like here. And our surgeons would go in, resect it, and in the past we give radiation, we give chemotherapy, but most of those children actually died despite all of that. And this is where we said, what is the problem? Why did these drugs can't get in? Well, the blood-brain barrier has been the biggest issue. So what we designed was, let's take an antibody called 8H9, labeled it with an isotope like a drug conjugate, inject it directly into the CSF so that the entire CSF space is going to be protected and these tumors will not come back. This is a model that we've copied from leukemia. As you know, leukemia is curable today because we started CNS prophylaxis. And this is essentially the same idea. We treat this CSF space with this kind of drug conjugate or radiolabeled antibody, we in fact could maintain the remission for these children past 14 years after the brain relapse. So I think that this is, again, suggesting that for some of these tumors, in particular neuroblastoma, a single target, a single antibody is curative. And this, I think, is a big lesson, at least for me. that we need to think through targets again. What is the right target and what is the wrong target? I think for some tumors, there's a right target. And I break it down here looking at patients who were treated with what we call the standard regimen for CNS salvage versus those who did not get the standard regimen. There's a difference. But again, these are fine-tuning. But in general, though, the CNS metastasis now is a salvageable complication. And it's all done outpatient. And for those who know, this is a treatment procedure that is done in the outpatient clinic. And the child would go home on the same day. There are some side effects like headache, maybe some vomiting, but these are all transient. But one thing I want to note is here is the toxicity. And as I said, you start throwing tomatoes to me because I started this whole thing about anti-GD2. But the thing is that I always said pain is bad. Pain is absolutely bad. But if you can hang on there for an hour, it's okay. If this is my child, I would do that because I'm looking for the ultimate cure. And we try very hard in everything we can, modify the pain regimen. And so far, what we found was the pain regimen doesn't really work so well. So we actually shortened the infusion in contrast with what's being done in Europe and lengthening the infusion. We shortened the infusions to half an hour, and the pain is identical. And the main thing is that it's all outpatient, and we've been doing it now for more than 15 years. It's all outpatient procedure. They get treated, and they go home. And the thing that is also striking is that they walk home now. The reason I say that is that we have never seen, after treating 894 patients with mouse 3F8, we have never seen a transverse myelitis. We have never seen a motor neuropathy because these kids walk home. They get out of the clinic. Now, this is a little bit different experience from the dinutuximab. Now, I don't know exactly what the reason may be. It could be because of the IL-2. It could be because of the fine binding kinetics of the antibody. It could be the PK. We still have to sort this one out. But there's something about these antibodies that, although they bind to the same antigen, they're actually not identical. So based on that, as I said, one antibody possibly cure. Why? Well, we're looking at a GD2 target. Why don't we go a step further? If we can treat the patient with an antibody against GD2, why can't we develop a vaccine against GD2? And this is exactly what we did. So we take GD2, GD3, and coupled it to a protein called KLH. And this is a standard protein that people use to make vaccines. You inject it subcutaneously with an adjuvant called QS21, and the vaccine is given on a weekly basis initially, and all the way up to 52 weeks. So it's a total of 7 injections, and it's an outpatient procedure. It is irritating, I have to say, by injecting locally. But again, patients go home after half an hour or so. So this is a very tolerable treatment. The first phase 1 study we did, which is shown in the blue line, are patients who are in the second remission. These are patients who have relapsed, got back remission, and got treated with the vaccine. We were excited by that phase 1 study because these are patients who have relapsed from neuroblastoma, got back into remission, and went on the vaccine. So their survival was now up to beyond 10 years, and they were still okay. Now, I do have to say, though, I think 1 or 2 of them are living with disease. They're not completely clean of disease. So we started the phase 2 study. Now we have 98 patients, and the survival curve is very similar, that we have essentially confirmed our initial phase 1 data to say that you could produce a long-term survival with this kind of vaccine. But again, about a third of these patients actually are living with disease. They're not completely clean of disease, but they're surviving. And that's why we started our phase 1 study, our first remission study, where we're actually now taking patients who get the induction therapy, get the antibody, and then go into vaccines. So here's our regimen. Relatively simple. We actually do induction therapy, harvest, and then local radiation, which is our standard 2100 in the past. We actually cut it down to 1800, and we're moving down to even further. And the reason for cutting down the local radiation is because we are seeing an incidence of diabetes, that abdominal radiation, at least in some children, are causing diabetic predisposition. So we want to lower the dose if we can. Second, we saw was short stature. That our children, once they get the radiation, they seem to be losing height. And we think that part of that has to do with the radiation to the abdomen. So we're going to cut back a little bit on that also. And then we will give antibody, 5 cycles, and then the vaccine. So this is our regimen right now for our upfront induction. Now you may notice that we didn't do transplant. And this is a controversy that we've been propagating, you might say. The way we look at this is the following. One transplant doesn't work, we're quitting. We're not going to go back and do it anymore. Instead of doing 2 transplants, we kicked out the transplant completely and we focus on immunotherapy. So there's a difference in approach. Granted, I think there's a lot of data that suggests that there's an improvement in disease-free survival, but the issue has always been overall survival. The impact on overall survival for many of these randomized studies, except for GD2, has not been very obvious. So this is why we are moving away from it. Now, the antibody 8H9 was licensed to a company called Y-Maps. It got FDA breakthrough designation. Hopefully, it will go through a fast-track approval. It's going to be used in multi-center. It's probably going to move to Europe. And I'm hoping that this will be done more than one place. And the reason I say that is because 8H9 actually has exciting data when we look at a tumor, which is not neuroblastoma, but DIPG. And DIPG story is still evolving, and I think that there's more to come. And you probably hear some of this in presentations, but there's a lot that's coming online or going to be coming in the future, which is really exciting. The other thing is humanized hu3F8 is also licensed to Y-Map, and again, it's going through the same process. And I want to mention this for a reason. And that is that as we develop drugs, and we develop drugs in-house, using our own, obviously, funding, and a lot of help from parents group. And parents has been the major funding agent for making humanized hu3F8. And just think about it, humanized hu3F8 is now being used in hundreds of children and make a difference in many of the children, have gone on to combination studies with NK cells, with bispecific antibodies for arming T cells, and so on and so forth. So it has really started the whole process, which was never intended in a sense at the beginning, but this is what happened. And I thank the parents actually for that. Moving on though, there's a future. And this is, I get more excited. Because what we know in the past is limited. It's limited in terms of its technology and in terms of its potency. We're in a new era now where stuff is really potent. So looking at this cartoon again, we've been using NK cells to do ADCC. We can make all kinds of modifications of this protein using special sugar residues to make it much more potent, much more powerful in using NK cells. That's one route. Another route we're doing is to make a bispecific antibody, which is an antibody attached to it, an apron string, I call it an apron string, that would grab T cells with it. So you can imagine the antibody would go to the tumor and then it grab T cells together into the tumor. And this is how we actually drive T cells into the tumor. And as you know, in pediatric tumor, most of them are what we call cold tumors. They don't respond to PD-1 or PD-L1. In fact, pediatric has been the least responsive in terms of checkpoint inhibitors. And the reason for that is because there were no T cells in those tumors. So this is a way to drag them in there. Another thing we are doing is actually using another apron string. This time, this is specific for a small ligand called DOTA. DOTA is the little chelator that people use for gadolinium. When you get an MRI scan with contrast, that's a little chelator called DOTA that will conjugate or grab onto the gadolinium that given intravenously. But there's a reason for that, because this DOTA, as you will see, is what we use to chelate metals, and especially radiometals. One thing that is everybody, I don't think there's any argument with this, Madame Curie started looking at radium. I think she was doing it with a really the goal to try to use it for medical purposes. Obviously, she died from it. And the reason why that is that at that time, there were no good ways to chelate a radium. to drive it to where you want. So when you ingest radium, it goes to the bone and it poisons the bone marrow. But we know that certain isotopes, and especially alpha-emitting isotopes, will deliver a damage that is not repairable, meaning there's a double-strand DNA break that is not repairable. And this is powerful because if you can do that and take it to the tumor, you can eliminate tumor pretty dramatically. And just to show you what is an alpha emitter is a lead basketball. And when you get hit by one of those things, you'll be pretty damaged. Versus a baseball, which is a beta, or a gamma, which is a ping pong ball. So this is what we're trying to focus, a beta particle and an alpha emitting particle. And the classic difficulty with drug targeting has been when you take anything that is conjugated to an IgG, IgGs are these antibodies that we give to people, they stick around in the body and they keep poisoning the body because they don't come out, they don't get metabolized. And the ratio of what is in the tumor versus what's in the blood is at best 3-to-1 or 5-to-1. So if I give 5,000 rats to the tumor, you get 1,000 rats, not survivable. So you need to know already, using the classic method, either for drug conjugates or for radioisotope, you will never get the kind of therapeutic index you really want. So this is where we're going into multi-step. There are other reasons for multi-step, but one of the scientific reasons is that we can now give an antibody without any radioisotope, just the fact that it's bispecific. It will go into the tumor, bind to the tumor, but here's an apron string that is sticking out here looking for DOTA. But you don't give the DOTA until a later point. At this point, when everything has been cleared out from the blood with the clearing agent, you give the DOTA chelated with an isotope, and that's what your ratio is. In the tumor is brown, in the blood is green, and the ratio is dramatically different. And what would that mean? What that means is you can cure now tumors like neuroblastoma. Actually, neuroblastoma is one of the easiest to cure using radiolabeled therapy. And these mice, not the fact that they were cured, when we look at the histology, there was absolutely no evidence of any radiation damage. The mice basically said, I have never seen radioisotope. At the same time, though, the tumor is gone. So that is a big lesson for us, that this approach, and not surprising, when you look at the ratio, is 142-to-1 tumor to blood. What we now are pushing is, has always been, is that we need to make these drugs available. And over the years, we've been actually manufacturing them. It's a big hassle, I have to tell you. It's a big hassle to take a blueprint, make a drug, a cell line production, purified it, IND, ILB, clinical trial. It is a nightmare. For those you just heard today, just the clinical aspect was a nightmare. But when you talk about manufacturing a drug, it's a nightmare. But we've been able to squeeze by over the years. And partly because we have parent support. We have foundations to support some of these pilot studies. And people would tell you, we'll take $1 billion to develop a drug. I said, that's not true. You don't need $1 billion to develop a drug. You find the right drug, you're going to make it, and you can spend some money, but it's not something beyond the reach of any of you here. So this is what we've been doing over the years. Mouse 3F8, mouse 8H9, we did beta-glucan, A1G4, which is an anti-D type, and so on and so forth. And the idea being is we really want to get it to the clinic. So the model we use now is we'll develop drugs for children. We may use philanthropic support. We may use government support. And then we want to take these drugs and get it approved in pediatrics and then let it use in adults. So we want to flip it, meaning that why have to make a drug approved in adults first? Get it approved in pediatrics, and then the adults can use it. The reason for doing that is that now I can tailor the drug I want to make, not a trickle down, whatever the adults have, and take whatever they give us, but rather make a drug specific for a tumor, specific for a purpose, whether using T cells or radioisotope. Of course, I have to thank a lot of people, a lot of foundations, a lot of people spend years and years of work, and I try to put the names and the faces on the slides, and probably some of the physicians. But it's a village. It takes a village to do all these things. It's not a one-man show. But I was lucky. I got the right people. And that's been, I think, something I can go to my tombstone with, that I've done something. Thank you.